Assalamu alaikum and a very good morning to you all. I am Dr. Tasneem Hossain from National Institute of Cancer Research and Hospital. I'm going to present my work on efficacy of radiotherapy for ovarian ablation in metastatic breast cancer. Comparison between 15 gray in 5 fractions and 20 gray in 10 fractions. Breast cancer is the most common cancer worldwide and fourth leading cause of cancer death. According to Globocan 2020, it ranks first among the Bangladeshi women. The incidence rate is 17 and mortality rate 9.3 per 1 lakh of population. Of this tremendous case burden, a good proportion of patients are premenopausal and as high as 60% are hormone receptor positive. Among the metastatic case burden, only 10% are de novo metastatic. The main aim of treatment in metastatic setting is control of tumor burden and maintenance of quality of life. Hormone receptor sensitive metastatic breast cancers with minimal symptoms and limited visceral metastasis are candidates for upfront hormonal therapy. The history of hormonal manipulation by ovarian ablation dates back to 1896 when Dr. George Whitson first discovered the benefit of oophorectomy in breast cancer patients. Along came radiation-induced ovarian ablation and medical ovarian suppression by LHRH analog. The fourth form of ovarian suppression is by chemotherapy. The rationality of this study lies in the fact that a large metastatic case burden is observed in Bangladesh. For premenopausal hormone-sensitive metastatic breast cancer patients, ovarian ablation for radiotherapy is a cost-effective, reasonable, non-invasive, patient-compliant procedure. A range of 10 to 20 gray has been historically used over the years. In search of an optimum yet efficacious treatment schedule, we compared conventionally fractionated 20 gray in 10 fractions over 2 weeks with 15 gray in 5 fractions over a single week, as it reduces hospital visit cost and machine occupancy. In order to compare between these two fractionations, we aim to compare the efficacy in terms of response, that is development and persistence of amenorrhea for 3 months, and hormonal response by FSH and estradiol values. Toxicities were measured of the acute radiation toxicities and development of postmenopausal symptoms. The study was a quasi-experimental study which took place in Department of Radiation Oncology, National Institute of Cancer Research and Hospital for a year, and purposive sampling technique was used. All the patients were hormone receptor positive metastatic breast cancer patients who were premenopausal and who have had regular menstruation within the last 12 months, having premenopausal level of serum FSH and estradiols. We did not take any patient who had gynecological pathology, who had visceral crisis, who desired future pregnancy, who had prior pelvic radiotherapy, or who had prior chemotherapy within the last 1 year. Total 68 patients were divided among the 2 arms, and patients were assessed after 6 weeks, 12 weeks, and 24 weeks of radiotherapy, and then final analysis was done. Radiotherapy planning, let's look shortly on the radiotherapy planning. 2D simulation was used. The inferior border was taken at the mid-obturator plane, the superior border at the lower border of lumbar 5 vertebra. The lateral borders were 1.5 centimeter lateral to the true pelvic brim. Now let's look at the results. Most of the patients in both arms were of the age group 36 to 40 years of age. Most of them had metastasis on progression, and most had bone-only metastasis. Few had visceral metastasis. Most of the patients in both treatments arm had invasive ductal cell carcinoma grade 2, and mostly they were both estrogen and progesterone receptor positive. When we analyzed the risk factors, the most commonly occurring risk factors were use of oral contraceptive pill and early age at menarche. BMI was observed, and about 30% of patients in both arms were overweight and only a few were obese. So in terms of baseline analysis, when we compared between the 2 arms, there was no statistically significant difference between the 2 arms. Previous treatment history was analyzed, and most of the patients in both treatment arms received chemotherapy, and as high as 40% patients in both treatment arms received no previous hormone therapy. Let's look at the response. After 24 weeks, 8.8% patients in arm A and 5.8% patients in arm B did not develop amenorrhea. The same patients did not develop postmenopausal level of estradiol that is less than 30 picogram per ml after 24 weeks. And further 20% patients in arm A and 11% patients in arm B failed to develop postmenopausal level of FSH that is more than 22 milli-international unit per ml. Analysis of the hormonal levels in both treatment arms revealed that there was no statistically significant difference in terms of mean hormonal value when measured at baseline 6th and 12th and 24th weeks post-radiotherapy. But a significant fall of serum FSH and a significant rise of serum estradiol value was compared when compared with the baseline value at the end of 24th week. Further investigation was conducted in search for factors responsible to failure to achieve ovarian ablation by radiotherapy. A significant association was found with baseline high estradiol value and attainment of response in estradiol level. The mean was around 116 picogram per ml. Also, a positive association was discovered with overweight and obesity. Again, a significant association was observed with absence of previous chemotherapy in regard to failure to develop postmenopausal FSH and estradiol values. Young age of patient was significantly associated with failure to develop amenorrhea, all patients being in the 26 to 35 years of age group. However, a longer follow-up period would have been required. Radiation-induced toxicities were analyzed according to the CTCAE guideline version 5. No grade 3 or 4 toxicities were observed between the arms. Most commonly occurring toxicities were vomiting, nausea, abdominal pain, without any significant difference between the two arms. Postmenopausal symptoms were analyzed according to the menopausal rating scale in respect of 11 symptoms, and most commonly occurring symptoms were hot flash, palpitation, irritability, insomnia, etc. There was no significant difference among the arms. So after thorough observation and analysis of 1 year, we concluded that there is no difference in efficacy of radiotherapy for ovarian ablation between 15 gray in 5 fractions over 1 week and 20 gray in 10 fractions over 2 weeks in management of premenopausal hormone receptor positive metastatic breast cancer patients. However, some factors were found to be responsible for failure to develop radiation-induced ovarian ablation that were young age, prior absence of history of chemotherapy, high BMI, and high baseline estradiol values. These are the references I used in my study. I acknowledge all who helped and guided me through the period for doing this study. I am very much grateful to them. Thank you to dear audience for your patience hearing.